I don't know. Let's see. So, bachcha log, you can hear me? एक second. Am I live? Am I live? Not live. Ah, live. Perfect. Okay, so we'll have to share this link basically. I don't know. Let's see. बच्चा लोग, you can hear me? एक second. Am I live? Okay. Yeah. Perfect. Okay, so we'll have to share this link basically. Let's see. Hi guys. So there was some problem with my old link. That is why it was not opening. So can we just share this link before we start? Yes. Okay. So guys, can you share this link on my Telegram group, please? Yes. Okay. Right, guys. So let's start. Just a second. Okay, guys. So let's start. Let's have a rapid round so that you can see what all questions can come and what all is little bit difficult, which can be asked to you in exam. So this is the first question on the screen. Okay. So don't worry, I'll be giving you PDF of this also. Okay. So for now, just concentrate on what I'm going to tell you here. So this is the first question. This was one of the repeated questions which was asked, and this is another question that can be asked. So which is true about thromboelastography? Okay, so which of the following is true about thromboelastography? Okay, so the question here is wait. Okay. So which of the following is true? Pin rotates, cup rotates, or both rotate, or uh, none of the above. So you should try to answer also, guys. Okay. So just try to answer the questions. I can just see what you're trying to answer also. So what do you think is true about thromboelastography? Right. So guys, whenever we are talking about thromboelastography, this is a viscoelastic testing. Okay, viscoelastic testing. And you know what is the property of what is the utility of this testing is this test is a very rapid test, number one. Number two, it gives you results in 30 minutes. It does not just correlate with one parameter like PTA, PTT. It gives you the complete properties of your body, starting from platelet, coagulation system, and fibrinolysis. So it has the beauty of giving all the things together. Okay, that is why it has also been introduced as point of care testing in the coagulation testing. Okay, so this is very good. Now, what is the difference between the two tests? So normally we have thromboelastography, which you all know. Okay, a slight modification of it has come, which is also called as rotational thromboelastometry, which is called as ROTEM. Okay, rotational thromboelastometry. Now, what is the difference between both of them is when it was launched as thromboelastography, so cup used to rotate. Okay, cup used to rotate, but so this cup, when it rotates, it's TG. But when pin rotates, okay, suppose the pin is there and it is rotating, then it is called rotem. So remember, P, what comes after P? R. So rotem, what rotates in rotem? What rotates in rotem? P. Pin rotates. So whenever we have pin rotation, that is rotem. Now this is a very important question that can be asked to you again. Now, interpretation of thromboelastography is one thing which everybody asked me to cover it. So, guys, you should know this again. So whenever we are talking about thromboelastogram, guys, we are getting this type of graph. Okay. So whenever I'm talking about this type of graph, you should know that it has some parameters. So as soon as you put, blood in it, so first the clot formation time, that is time to form clot. Okay. So I'm talking about TEG graphs, okay, thromboelastography graphs, okay. So first, time to take clot is given as R, okay. So this is the time to form the clot, and it is dependent upon your clotting factors, especially intrinsic clotting factors, okay. So whenever we have deficiency of intrinsic clotting factors, what is going to increase? R is going to increase. So R is dependent upon intrinsic clotting factors. Now immediately after this, what happens is once the clot is formed, now it starts forming. So when the is formed, now after that it starts getting little strength. Okay, so that strength, okay, is so this is the strength. Okay, so till the time it reaches a particular strength, this time is called K. So till the time it reaches a particular strength, it is called K. Okay, and the angle, the speed in which it is formed is called alpha angle. Okay, so both K and alpha angle are dependent upon fibrinogen. Okay, so both K and alpha angle are dependent upon fibrinogen. Okay, then what happens is the clot reaches its maximum height, that is maximum amplitude. This maximum amplitude is dependent upon platelets. Okay, so maximum amplitude, and this was the question which came in the last year exam. Maximum amplitude is always dependent upon platelets. And after the clot is formed, fully formed, now what happens is after the amplitude has reached, now obviously everybody cannot reach till the always remain at height. It has to fall also, isn't it? So now the amplitude will start falling slowly. Okay. So now when the amplitude starts falling, okay, so 30 minutes after maximum amplitude, how much ever lysis has occurred, it is called as lysis 30. This is called as lysis 30, and it is dependent upon fibrinolysis. It is dependent upon fibrinolysis. Now that is very, very important. So remember these graph basically. So when we talk about R, it is dependent upon intrinsic clotting factors. When we talk about K and alpha angle, they are dependent upon fibrinogen. When I'm talking about maximum amplitude, it is dependent upon platelet. And when I'm talking about lysis 30, it is dependent upon fibrinolysis. So basic on this, they can give you some graphs which can be asked to you in exam, and you should be very, very clear on these graphs, guys. Okay. So normally it is like a brandy sniffer. Okay. So don't look at the base. Base is not mattering. So this is nothing but, R. Then we have K, alpha angle, maximum amplitude, and then a slow lysis occurs. So that's normal graph. Now, suppose it becomes like a red wine glass, like that means this R is increased. Okay, so R becomes very much increased. So this means there is a factor deficiency. So why do you do thromboelastography? Is because it is on site bedside test to give therapy. So once you do take the blood, okay, so suppose your patient is you doing cardiac surgery, or the patient is trauma patient, he's coming to you. Once you take the sample and you do this and you find that R is increased, you immediately know that there is deficiency of clotting factors. So immediately you give FFP to this patient, okay, fresh frozen plasma to this patient, so that you're giving all the intrinsic factors. Okay, so FFP is a therapy to be given when your R is increased. Now let's go to the other thing. Okay, suppose it becomes like a champagne glass. Okay, so champagne glass means R is increased for sure, but now you can see that K and alpha angle is also increased. Okay, so K and alpha angles are also K is increased, alpha angle is decreased. So instead of becoming like a wine glass like this, it is becoming like a champagne glass. So alpha angle is decreased, and your definitely that means the thickness, the firmness of the clot is not coming. That is why your K is also less and your alpha angle is also less. That means along with the deficiency of intrinsic factors, your fibrinogen is also decreased. Your fibrinogen is also decreased. In such cases, you need to give more fibrinogen to the patient. So for this, you give cryoprecipitate. Okay, so you give cryoprecipitate. Okay, so cryoprecipitate is given for this condition where your alpha angle is decreased. Okay, now let's go to the opposite thing. Now what happens is that everything is okay, but what you say is that the maximum amplitude is decreased. You see that maximum amplitude is decreased. It has become like a test tube. So like a test tube, that is maximum amplitude is decreased. So maximum amplitude was dependent upon platelets. So what will you give? Platelets. Obviously, give platelets and the patient will improve. So you have to give platelets to this patient. Now look at the opposite side. Normally lysis should occur slowly, like a brandy glass. Okay. Suppose it is occurring very fast, like a martini glass. So it's becoming like a martini glass. Okay. That means fibrinolysis is occurring very rapidly. So in this case, that means your fibrinolysis is increased. So you have to give thromboxylic acid, your antifibrinolytic agents. So give antifibrinolytic agents in these conditions. Do you understand that, guys? Everybody? Yes? Okay. So, understood? Is everybody clear with this? Yes. So that is your graphs which you can see. So Abhishek, is it okay now? Right? So you can see, so remember this basic thing, okay? So when it becomes like a red wine, okay, a red wine glass, that is your R is increased, you're going to give FFP. Whenever it is becoming like a champagne glass, that means your alpha angle is decreased. Okay, in that case, you're going to give cryo. When your maximum amplitude is decreased, in this condition, you're going to give platelets, and it is becoming like an inverted martini glass, that is fibrinolysis is increased. So you're going to give antifibrinolytic agents. So these are the common thromboelastographic patterns, and they can ask you any question. What will happen when R is increased? What will happen when alpha angle is decreased? What will happen when maximum amplitude is decreased? What will happen when your lysis 30 is increased? Okay, so you should be able to answer all these questions. It's a very simple thing. If you understand, you will not do it wrong in your exam, right? So that is first thromboelastography. Now let's come to the blood banking question. Again, a very simple question. I'm sure all of you would have studied this, but let's see how many of you can answer this. So you're called to the bedside for a post-operative patient who is hypotensive. Okay, he's febrile and he has an acute onset of respiratory distress following initiation of blood transfusion. So, which of the following will be most appropriate initial action of management in this case? So, you tell me what is the diagnosis in this case, guys? What is this patient suffering from? His BP is falling and he's getting respiratory distress immediately after starting transfusion. So, what is this patient having? Quick. So I'm sure all of you would have made the answer that this patient is having transfusion associated lung injury. That is TRALI. This patient is having TRALI. Very good. So once you get TRALI, what is the first thing that you're going to do? Immediately you're going to stop transfusion. That's the first thing, because this is a cause which is due to transfusion. You have to stop the transfusion. After that, you give oxygen, you call the blood bank and give steroid, which is called ABC. Apply oxygen, A. B, call the blood bank. C, give the steroids. Okay, only after you stop the transfusion. Okay, so remember, whenever I'm talking about transfusion reaction, this is a very important tentative question which can be asked to you in exam. Remember, transfusion reactions could be acute or they can be delayed. Acute means which occurs within 24 hours. Now, again, they can ask you immunological and non-immunological, guys. So when I talk about immune, okay, that means some antibodies are concerned in it. So most common immunological acute transfusion reaction is febrile. So febrile non-hemolytic transfusion reaction is the most common acute transfusion reaction. Okay, followed by allergic. The second one is allergic. Okay, so first is definitely your febrile. The second one is your allergic. Okay. After that comes your TRALI. After that comes your TRALI. Now there is one more acute transfusion reaction which is very very dangerous, which is called as acute hemolytic transfusion reaction. What is it called as? Acute hemolytic transfusion reaction, guys. So whenever I'm talking about acute hemolytic transfusion reactions, remember, this is because most common cause of acute hemolytic transfusion reaction is ABO incompatibility. It is a clerical error. Okay, so you do not match the blood group properly between the donor and the recipient. So that causes acute hemolytic transfusion reaction. Okay, that is the most common one that you have to remember. Followed, so that is one of the clerical error which you should remember. Apart from that, we have talked about febrile, allergic, and TRALI. When I'm talking about non-immunological, guys, in non-immunological, remember we have a major one which is called as TACO. TACO is non-immunological. Okay, so remember this one. Okay, so TACO is non-immunological. Okay, yes. So TACO is non-immunological, and this is transfusion associated circulatory overload. Apart from that, all the bacterial contamination, all the physical hemolysis, okay, occurs non-immunological. So they are acute, but they are non-immunological. Okay. Now, when we talk about delayed transfusion reactions, guys, you have to remember when I'm talking about delayed transfusion reactions, again, delayed means after 24 hours. Again, it can be immunological or non-immunological. So whenever I'm talking about, I'll tell you, Abhishek, I'll tell you. So when I'm talking about immunological and non-immunological, again, you have to remember here in immunological, you have to remember there are two important causes. Okay, one more is there, but two first. Okay, first is transfusion associated graft versus host disease. Transfusion associated graft versus host disease, and post transfusion purpura, so post-transfusion purpura and transfusion-associated graft-versus host disease are two delayed immunological reactions. Apart from that, delayed hemolytic also occurs, which is due to minor blood groups, okay, like Duffy blood group mismatch, okay. They cause delayed hemolytic transfusion reactions, okay. Now, apart from that, non-immunological also occurs. Delayed non-immunological. What happens? You would have studied some case reports earlier, no? Patient was given blood and after that he became HIV positive. So this is disease transmission, which is years after. So this is usually delayed transmission of infections and delayed, like thalassemia patient. You keep on giving them blood and they develop hemosidrosis. That's also delayed transfusion. So delayed basically is your transfusion associated hemosidrosis and disease transmission. Okay, so once you're clear with this, okay, everybody's clear with this. Now let's come to the causes which they can ask you. Okay, here the two important causes that you have to remember is why does trali occur? That's the first thing you have to occur. Why does trali occurs? Okay, so what happens is when you're giving the so first thing is trali usually occurs whenever you're giving plasma products. Okay, so products in which there is more plasma, they are the culprits for trali. You know why? Because the donor plasma has some antibodies against the human neutrophil antigens of the recipient or HLA, usually HLA type 2 of the recipient. So what happens in this patient is donor plasma has antibodies. Okay, donor plasma has antibodies against neutrophilic antigens of the recipient or against HLA molecules of the recipient. So these antibodies quickly go and they act. So that is why trali occurs within 6 hours of transfusion. Number one. Number two, because these antibodies are against the neutrophilic antigens, they activate the neutrophils. Interleukin 8 is released, which activates the neutrophils, and it also causes sequestration of leukocytes inside the lungs. So that is why there is injury to the type 1 and type 2 pneumocytes and endothelium, which causes trali. Okay, right? Is everybody clear with this? Okay, so wait, let me see. Are you able to see my screen, guys? Wait, let me see. Just let me see if you can. Are you able to see my screen, guys? Wait, just a second. Just a second, guys. I think you are not able to see what I am sharing. Just a sec. Wait. Is it coming? I think screen is not sharing. Let's see. Just see. एक second. Wait. Now can you see the screen? Uh, no, screen is not sharing. Right? I'm sharing this screen, but it's not moving. Wait, wait, let me see. Okay, let me see. I think today our YouTube says there's some jinxed session only. Anyhow, you can hear me or you see me? Okay, now, yes, now I think you can see the screen. Perfect. Okay. So this was what I was telling you guys. So about transfusion reactions, we have just now quickly talked about. So quickly, let's revise. We talked about acute immunological transfusion reactions quickly. So what were acute immunological quickly? Most common is febrile, followed by allergic, followed by trally, and acute hemolytic. You all should know it's a major blood bag, ABO incompatibility. Okay, and it is a major emergency. Non-immunological, I told you, TACO you have to remember, and the bacterial contamination. Okay, now, coming to the delayed immunological, okay? So when I'm talking about delayed immunological, guys, remember we have talked about transfusion associated graft versus host disease, post transfusion purpura, and hemolytic, which is minor blood group like Duffy, okay? And apart from that, non-immunological was infections and hemosiderosis. So I told you what was the cause of Trally. Trally was because of, so what was the cause of Trally? Trally was because of antibody in the donor plasma. Okay, donor plasma basically has the antibody against human neutrophilic antigens and HLA antigens of the patient, and that is what causes Trally. Okay, but if somebody asks you what is the cause of FNHTR, that is febrile non-hemolytic transfusion reaction, one is cytokines, which you should remember. The second one that you have to remember is the recipient has antibodies against donor lymphocyte. So it is ulta, bilkul ulta. Donor bag has some lymphocytes and recipient has antibody against donor lymphocytes. So this is very, very important. So antibody against donor lymphocyte and HLA antigen causes febrile reactions. Do you understand why is it important? Because if you cause leukoreduction, then automatically the febrile reactions are going to decrease. Okay, so that is why we do leukoreduction in patients who get recurrent transfusions like thalassemia patients. Okay, so remember, this is very, very important. Also remember, whenever I'm talking about acute hemolytic transfusion reaction, is type 2 hypersensitivity reaction. Okay, it's type 2 hypersensitivity reaction, which you all should remember. Okay, right. So these are just one-liner points which can be asked in the exam. So I've just added it in the PDF so that it is easier for you to revise. Okay, right. Now, coming to the next question, which is again very commonly asked, what is the difference between Trally and TACO? Remember, TACO has hypertension, and that is why the question that I gave, I told you the patient has hypotension. So TACO, whenever it occurs, it usually has patient has hypertension, and you do a BNP, which is more than 250 picogram per ml. So that's the difference between Trally and TACO, which usually you should remember, right? Okay, and also remember TACO is non-immunological reaction, Trally is immunological acute reaction. Remember that point always, okay? Now, Coming to the very, very important point, that is anticoagulants. Okay, so whenever I'm talking about anticoagulants, this is another question that they ask you. Okay, most common anticoagulant that we are using now is a blood, basically it's a blood additive, which is sagum. Okay, saline adenine glucose mannitol. But otherwise, what are the other anticoagulants? So earlier when we started with ACD, but the life of the blood was very less, that was 21 days. Then we used CPD, that is citrate phosphate dextrose. Remember the work of citrate. Citrate is the anticoagulant. Okay. Phosphate is the one which prevents fall in the pH, and dextrose provide, glucose, so it provides ATP. Okay. So CPD. Okay. So at that time, some says its life is 21 days. Some book says its life is 28 days. Okay. Then we came up with the fixative, which is anticoagulant, which is very commonly used now. That is CPDA, that is citrate, phosphate, dextrose, and adenine, guys. So remember, whenever I'm talking about CPDA, so apart from citrate, which is an anticoagulant, okay, phosphate, which is a pH maintaining, okay, dextrose, which is a sugar containing, which provides ATP. Adenine is the one which synthesizes the ATP, so it increases the shelf life, and shelf life has increased to 35 days. So shelf life has increased to 35 days, okay. And then we have sagum, which has a life of 42 days. Okay, so sagum is very, very good because it has mannitol, which even preserves the pressures in the RBC. So it is very good. It increases the life of the bag to 42 days. So that is the beauty of anticoagulants, and it is a very commonly asked question. So you should be knowing that. Okay, coming to the next question, let's see how many of you can answer this question now. So let's see, you can answer this question or not. Okay, so in a patient with non-mismatched non-mismatched blood transfusion, what should be done first? Okay, so let's say patient has got a blood reaction and it is non-mismatched blood transfusion reaction. That is, you had done matching and everything was okay, but still he got blood transfusion reaction. What will you do first? Tell me, what will you do first? Will you do direct Coombs, indirect Coombs, antibodies, or stop the transfusion? So first thing that you should always do, guys, is very good. You should stop the transfusion. Okay. So first thing that you should do is stop the transfusion. So here is the question and the rule that is asked. So whenever you get a reaction, blood reaction, what are you supposed to do? Stop the transfusion is the first thing that you have to do. Immediately, what you should do first, you should do the clerical checking. Okay. So first thing that you should do after that is clerical checking. Okay, blood group was A, I have given A bag or not. Okay, so first thing is clerical checking, and then you take the post transfusion sample. Once you take the post transfusion sample, which samples should you take? You should take blood sample and urine sample. Why should you take urine sample? To see if we are having hemoglobinuria. Why should you take blood sample? So first you have to check that whether there is a hemoglobinemia. Second, you do ABO and RH testing again, whether your typing was correct. And the second thing you do is Coombs test. Next thing that you do is Coombs test, direct Coombs test. Okay. So these are the things you should immediately do once you get a transfusion reaction. Okay. So first thing you do is clerical check, followed by ABO and RH typing and direct Coombs test, and also check for hemoglobinemia, right? So that was what you were going to do. After that, you go to second tier testing, which is more tests. But these tests, at least you should be knowing. Now, here comes the next question. What is this test? Although we have discussed this in the last class also. So whenever you're revising, guys, go through both the revision sections that we have done recently in 2 to 3 days. Do revise all of them because all of them are important topics. So I'm not repeating the topics, okay? So they were also important topics. So this test is gel card method, guys. And what is the principle of gel card method? It's a column agglutination property. So this contains a gel, and gel has anti-human globulin, and if the cells are sensitized by incomplete antibody, they get trapped on the top itself. So anything which is coming on the top is considered as positive, anything which goes down is negative. Okay, so this can be done. I've told you this is anti-IgG and C3d card, which is a Coombs card, but we can use the same card for blood grouping, also for PNH typing with different. So for PNH we use 55-59, for blood grouping we will use the various blood groups. Okay, right? So this is gel card testing, which everybody should be able to know, right? Now let's go to the next question, okay, which again is a very commonly asked question. You should know what is the temperature of storage of the blood. Remember, whenever we're talking about any component of RBC, whether it is a whole blood or it is a packed RBC, the storage has to be at 2 to 6 degrees centigrade. And if you're taking this, you have to start the transfusion within 30 minutes and try to end it in 4 hours, okay? When you're talking about platelets, you store it at room temperature. You should agitate it in a platelet agitator. Remember, on the platelet agitator, the porous side of the platelet should be on the top so that platelets can breathe. And always platelets should show you a activity. This is called as swirling. That is, if you touch them, they should move round and round. So if you touch them, they should move round and round. That is what is called as swirling. That means the platelets are active, okay? So once you're doing that, the life of the platelet is 5 days. Again, platelets can be of two types. We can have single donor platelets and we can have random donor platelets. Okay, so if you're taking blood from a single individual and you are taking out platelets from him, this is called random donor platelet. Whereas if you're taking out platelets by apheresis, okay, that is called as single donor platelets. Irrespective of the type of the platelets, the life of the platelet is always 5 days only, okay? And you have to start the platelet transfusion within as fast as possible, at least within 20 minutes, okay? Now, third component that you should know is fresh frozen plasma. So fresh frozen plasma should be stored at least minus 18 degrees centigrade, and it has all the coagulation factors. And once you freeze them, they have the life of 1 year. Okay, to use fresh frozen plasma, you have to thaw the fresh frozen plasma. Okay, and when you thaw them, when you thaw it, then only you can use fresh frozen plasma. But once you have thawed it, the life of fresh frozen plasma is only 24 hours. Okay, so the life of the fresh frozen plasma is only 24 hours after thawing. Okay, after thawing. Now remember, the needle size for the platelet, okay, for any transfusion is 18 gauge needle, and the filter that you use is 170 to 260 micro units. Okay, so that is the protocol that we have to remember. So what we have read, this is the master chart of this. Okay, again I'll give you a PDF of it. It is super important. I've told you the same thing. For all the packed cell and whole blood, we have to store it at 2 to 6 degrees centigrade. What is the importance of this is, the question that has been asked is, what is the hematocrit of packed red blood cell? It is 65 to 75. That is the question that has been asked. And if you give 1 unit of whole blood or packed blood, how much hemoglobin is increased? It is increased by 1 gram per deciliter, or hematocrit is increased by 3 to 5%. Okay, and it has to be an ABO and RH compatible, obviously. Now, whenever I'm talking about platelets, I've already told you we have two types of platelet: random donor platelet and single donor platelet. Now, the difference is in random donor, because you're taking from blood from a single individual and you're taking out platelets from him. So you only get a platelet volume of about 50 to 70 ml. Whereas when you take by apheresis, you take approximately 200 to 300 ml of platelet itself, guys. So that is why it becomes very, very important. So that is why these single donor platelet bags are also called as jumbo bags. Remember, they can ask you, what is a jumbo bag? Jumbo bag is a single donor platelet bag. And remember, the life of both of them is 5 days only. But the difference is, when you give a one random donor platelet, the platelet count will increase only by 10,000. Whereas whenever you are giving a single donor platelet, platelet count will increase by approximately 30 to 50,000. So approximately, if you're giving a very good apheresis platelet, about 6 times. Okay, so one STP can increase the platelet up to 6 times. That is one thing you have to remember. Now, should it be ABO and RH compatible? Yes, it should be, because all the platelets, whenever you prepare, has some amount of RBC, and if you give them, then it can cause transfusion reaction. It has some amount of blood there. Okay, right. Talking about fresh frozen plasma, how much is the volume? 200 ml. I told you minus 18 is the minimum temperature that you should be using. It has to be for 1 year. Okay. Now, apart from cryoprecipitate, so what is a cryoprecipitate, guys? You should remember this, okay? So whenever I am talking about cryoprecipitate, what is cryo? So if you thaw FFP, okay, you have to thaw it in the water bath, okay? If you have to thaw FFP, you have to thaw it in the water bath. If you thaw the FFP at 4 degrees centigrade, if you thaw it at 4 degrees centigrade, then you will get a powder. This powder is what is called as cryoprecipitate. So from a 200 ml bag of FFP, you get only approximately 20 ml of cryoprecipitate. That's the volume. Okay, you get only 20 volume of cryoprecipitate. And cryoprecipitate, I've told you so many times, and I've posted it my Insta also so many times. It's rich in certain factors, which is always asked as a question. You should be knowing it. Factor 8, factor 13, two F's, fibrinogen, fibronectin, and von Willebrand factor. Remember that this is the composition. This is the composition of cryoprecipitate. So that is why it is used for von Willebrand deficiency. Okay, and you have to use it for hemophilia. Uh, so you have to use it for hemophilia A. Remember, it is not used for hemophilia B. So for what is cryoprecipitate not used? It is not given for hemophilia B. That's a very important point you have to remember. Now, what is the use of fibronectin is? It acts as a fibrin glue. So it causes immediately clotting, and that is why it is used for open heart surgeries. Okay, for open heart surgeries, you use fibronectin. So cryoprecipitate is never given for which hemophilia? Hemophilia B. Okay, is everybody clear with this, right? So that is your cryoprecipitate, which you have to remember. Okay, now one more question that they ask you is that if you have given cryoprecipitate, by how much does factor 8 increase? It increases by 2%. Okay, and do you require ABO and RH matching in cryoprecipitate? No, you don't. Why? Because the powder is formed. That powder is basically you don't require in ABO and RH because there are no red cells in it. Okay, so you don't require ABO and RH typing in cryoprecipitate. Okay. Now, there are the questions which have been asked so many times and which are not given in your books, okay, and they are asked in the exam. So these are unusual components. What are these unusual components, guys? One is washed red blood cells, okay. What is a washed red blood cell? You know, washed red cells basically are given for patients who have severe allergies or IgA deficiencies. In this, what we do is we take out the blood, we wash it with distilled water, okay, and we give it. But problem, you have made the system open, so it will get infected. So that is why the life of washed RBC is only 24 hours. So you have to use it within 24 hours, otherwise you throw it off. Okay. Now, in contrast to washed RBCs, let's go to the opposite thing. Frozen red cells. You know, when do you use frozen red cells? Special blood groups, Bombay blood group. You know, Bombay blood group can give blood only to the Bombay blood group. Okay, precious blood groups. Okay, so what do you do is you freeze the RBCs at minus 120 degrees centigrade. Once you freeze them, they have a validity of 10 years. They have a validity of 10 years, and the life of this is okay. Life is 10 years, and you use glycerol for this. Yes. Okay, so Abhishek, that is right. I've just now told you FFP. When we talked about thromboelastography, then I explained you whenever we have factor deficiencies, any factor deficiencies, we can use FFP. Okay, so that is why FFP is one of the components which you give when the R time of TEG is increased. Do you remember that we discussed it? So whenever we have factor deficiencies, we can give FFP. Okay. Right. Cryo we can give only when we have factor 8 deficiency or factor 13 deficiency or in afibrinogenemias, right? Okay, now let's talk about frozen RBCs. We have talked the validity is 10 years. Now coming to the radiated RBCs. Okay, so when I'm talking about radiated RBCs, why do you radiate them? So radiation basically makes the red cells incompetent. Okay, so they can't activate. Okay, once you radiate them, so now these basically the blood has a lot of WBCs. Okay, especially the T lymphocytes. These T lymphocytes are basically responsible for causing graft versus host disease, okay, which is called as transfusion associated GVHD. So who's going to tell me which type of reaction is transfusion associated GVHD? Is it acute or is it chronic? Quick, is it acute or is it chronic? Chronic मतलब delayed. it's delayed. Okay, and remember, it's immunological or non-immunological? Immunological. So it is delayed immunological reaction, and this occurs because of WBCs in the donor blood. Okay, so what do? You irradiate them. So what happens? These T cells are there, but they cannot activate cytokines, so they cannot cause GVHT. Okay, that is why we basically irradiate. So irradiated is to prevent graft versus host disease. Okay, that is the use. That's a typical use of radiated RBCs. Okay, now if you irradiate RBCs, then the viability. Okay, so if you're using a bag which contains red cells and you irradiating that, then the life of that bag will become 28 days. But suppose you are using platelets, which has you suspecting that it has some WBCs, and you irradiate platelets, then they will be only viable for 4 hours. Okay, so irradiated platelets will have the viability of only 4 hours, whereas irradiated RBCs will have a validity of 28 days. And whenever we have GVHT, remember, we have two type of GVHT, acute and chronic. So acute GVHT occurs within 100 days of transplant, and it typically affects three organs. Okay, remember, skin, liver and GIT. So any patient, transplant patient, within 100 days presents with rash, diarrhea and jaundice. Rash, diarrhea and jaundice. Okay, you should always think of acute GVHT. Okay, whereas if it presents with after 100 days, then he presents with systemic sclerosis like picture. Okay, remember that point always. Is everybody clear with this? So that is your GVHT, which you all have to remember. Now let's come to this question quickly, guys. So what is this? So this is a 24-year-old boy, and what did he saw is that when he was giving blood transfusion, the first amount, few mLs of the blood was going in this bag instead of going to the main bag. What is the utility of this bag? So guys, the first blood that we always get has, when you put needle in the skin, so skin bacteria can come in the blood. So you don't want the blood to get infected. So first few mLs of the blood is thrown into this bag. Okay, so this is called pre-donation bag, and it is to decrease the risk of bacterial sepsis, because all the bacteria which are coming from the skin will go into this, and then you will transfer the other blood into the main bag. Okay, so what is this called as? This is called as pre-donation bag, guys, and it diverts the first 30 ml of the initial blood into this, and it prevents bacterial sepsis. Now, who's going to tell me what is this? Have you seen this? This is another equipment that can be given to you in exam. This is biomixer. Okay, so if you ever seen a bag, it keeps on shaking in this. Okay, this is a biomixer. It mixes the blood well with anticoagulant, and it prevents microclots. Okay, because it helps in proper mixing of blood with anticoagulant. This is mixer, biomixer. Okay, what is this? If you look at this, this is called bio sealer. Okay, so when you have to seal the bag from anywhere, you use this equipment. This is bio sealer. Okay, right, very good. Okay, so bio sealer. Now coming to the filters, guys, this was another question that was asked. They were shown this filters and this filters. What is the difference between both these filters? Remember, this filter is the first generation filter. It's a very commonly used filter. All of you would have used in your internship. This is a clot filter, and it is about 170 to 250 micrometer. Then the second generation filters are just a micro aggregate filter for filtering out some platelet or fibrin thread. They have a size of 20 to 40 micrometer. And this was again a third filter that is there. This is called third generation filter. This is leukoreduction filter. So whenever we have to do leukoreduction, okay, leukoreduction, we do this for patients, first, in which you don't require allergies or febrile reactions, patients who are repeatedly transfused, like thalassemia patients. Okay, and the second is newborns. Okay, so your newborns also you should give blood through this, because leukoreduction prevents the risk of CMV infection. Okay, so it prevents the risk of CMV infection. Okay, now uh, what is a leukoreduction? Leukoreduction has less than 5 into 10 raised to power 6 WBCs. Yes, you can do residency. It doesn't matter, guys. Okay, right? So leukoreduction basically is to reduce the WBC less than 5 into 10 raised to power 6. That is the leukoreduction. That is the meaning of word leukoreduction. Okay, that is what is done with the third generation filters, and it prevents CMV infections and allergies and febrile reactions. Okay, now another question that is very commonly asked in transfusion is complication after transfusion, and I'm sure all of you know that, because for storage, if you store the blood for a longer time, it is going to cause hemolysis and potassium is going to come out. So it will cause hyperkalemia. Okay, apart from that, it can also cause hypokalemia because re-entry of the potassium will occur, and that is why it can occur. So we can also have hypokalemia. Okay, because you're getting a large amount of magnesium poor fluid, so hypomagnesemia can also occur. Because you're doing citrate overload, that is why hypocalcemia can occur. Okay, so these are major complications which can be seen after transfusion and can be asked as the question. Remember always. Okay, so calcium goes down, magnesium goes down, potassium goes down, but what is very common? Potassium going high is very, very common. Okay, apart from that, yes, it can have low potassium, low magnesium, and low calcium. Okay, remember, low hypocalcemia is very common in platelet pheresis. Okay, whenever you're doing apheresis, in that cases, because you're giving a large volume of citrate, it's going through your blood. That is why hypocalcemia occur, and that is why it is good to give calcium tablets to the patients. You keep giving calcium tablets so that to prevent hypocalcemia, right? Okay, now let's go to the next section. Okay, so this is another section of soft tissue tumors, which is again very, very important and can be asked to you in exam. Let's look at this question first and let's see how many of you can answer this. So this is a 14-year-old boy who presents with the swelling in the left tibia. X-ray shows an onion skinning pattern. Okay, and there are small dark nuclei on IHC. CD99 is positive and LCA is negative. Which of the following is this tumor? So guys, there are few clues in this. Onion skinning they have given, very good. That's a clue. It's swelling of the tibia. There is onion skinning, and they've given you a very strong clue. It's a small round cell tumor. They've given you a clue that it's a small round cell tumor. So yes, it's a small round cell tumor which is positive for CD99. I'm sure all of you would have come to an answer till now. This is Ewing's sarcoma. Okay. Uh, Alkalosis is more common, Abhishek. Okay, and if you can see, they have lot of cytoplasmic vacuolation. That is the catch point here. So yes, so because Ewing sarcoma tumors have lot of glycogen, that is why they are pass positive also. So if you look at these tumors, before we go to the image, look at these tumors, they are usually like this. Okay, so you'll see a lot of pass positivity in this. Wait. Okay, so you'll see just a second. Okay. So you'll see a lot of pass positivity in this. So look at the image that I'm showing you right away. So this image basically is showing you lot of cytoplasmic pass positivity. So this pass positivity is very, very typical of Ewing sarcoma. And if you look at these tumor cells, they usually have clear cytoplasmic vacuolation. That is what is seen in Ewing sarcoma. Okay, guys. So that is very, very important that you have to remember. Okay. Now, let's come to the mutation here because that's very, very important. So, these tumors are called as Ewing's sarcoma family of tumors, and usually there is a very typical rearrangement which you already know. So, basically, you have EWS gene which is present on chromosome 22q. Okay, and apart from that, there are ETS family of members which are there, and most of the time it is 11, but there can be other genes also. So these EWS family of genes get mutated. So therefore, the diagnosis of choice here becomes fish. On fish, you can see the fusion. You can see the fusion of this red and green signal. That is yellow color is coming here, which you can see here. That means yes, it is fusing and giving you that yellow color. That means that's a diagnosis of choice. And of course, if you put IHC, this is what is seen. You can see membrane positivity. All the membranes are getting highlighted. This is called membrane positivity. This is membrane positivity of CD99, which is also called MYC2 gene. Okay, so which is also called MYC2 gene. That's a very important thing that you can see in this Ewing sarcoma. So I told you Ewing sarcoma has a mutation of 1122, and remember it is always EWS on 22. EWS on 22. Okay, which again codes to ETS family of members. If it is FL1 of ETS family, this is 1122, which is most common translocation. Okay, so 11 is FL1. Basically, this is one of the most common translocation of Ewing sarcoma. So guys, some translocations which are very commonly given to you in exam, which you should always remember. So let me give you a clue to remember all of these. Okay, so first 1122, so you all know now that is FL1 EWS. Now question is, can 2122 be Ewing sarcoma? Yes, because 22 is EWS, okay, and in 21 sometimes ERG occurs, so it can also be Ewing's. Okay, apart from that, now we change the question, we change it to 922. I hope in hematology everybody knows 922 is for CML. Okay, but in soft tissue tumor, this is a very typical mutation for extraskeletal myxoid chondrosarcoma. So chondrosarcoma. So how do you remember? Remember CML starts with C, chondrosarcoma starts with C. So extraskeletal myxoid chondrosarcoma, both of them have 922 translocation. Both of them have 922 translocation. Now 1122 you've just seen is Ewing's. Okay, is there any other cancer which has 1122 translocation? Yes, a very rare. Usually they will not ask you this, but still, desmoplastic small round cell tumor. Okay, desmoplastic small round cell tumor also has 1122. Why? Because here also the translocation is between EWS, but instead of FL1 here we have WT1. Okay, now apart from that, clear cell sarcomas, when we talk, it is 1222. Okay, 1222 is clear cell sarcoma. Now, the question that was asked here was, so I've just told you 1216 was one of the question which has earlier also came in exam. This was basically for liposarcoma. Okay, this is what is more commonly asked. Okay, especially myxoid liposarcoma has 1216. Okay, so myxoid liposarcomas have 1216. Now, once you're clear with this, now I'm going to show you just a few things here. So whenever I'm talking about 12, no, so you know 1216 is lipo. So what is 1215 if somebody asks? That is fibro, infantile fibrosarcoma. Okay, so 1216 is lipo, 1215 is infantile fibro. Okay, so remember, this was again a question that has come already in your exam. If you have seen, 1215 translocation is a very important translocation for infantile fibrosarcoma, which is a very important jinx question also, which I had posted earlier. It came in the exam. Everybody should remember. Once you're clear with this, then two more translocations which you should remember. I'm going to just write it here. X18 and X17. Okay, so these are two important translocations that you should know. X18, everybody should know, it is synovial sarcoma. Very, very common. Remember, synovial sarcoma is one sarcoma which is biphasic sarcoma, and it has both epithelium and as well as mesenchymal uh, components. Okay, it's a biphasic tumor. Okay, X17 is again a very important cancer which is called as alveolar soft part sarcoma. X17 is alveolar soft part sarcoma. That is what you have to remember. Alveolar soft part sarcoma is X17. Okay, very, very important that you should remember. Okay, now these are the common ones you have to remember. Now you'll say, why ma'am you're not talking about rhabdo? I'll come later. Okay, but apart from that, you have to remember 1122 you have to remember for Ewing's, everybody. Apart from that, desmoplastic small round cell tumor. 922 you have to remember two C's, CML and chondrosarcoma. When you talk about soft tissue tumor, we have lipo and fibro. Okay, very close. Lipo is 1216, fibro is 1215. Okay, finished. Now, the fibro is infantile fibro. Remember that always. Okay. Apart from that, there are two X18, X17. X18 is synovial sarcoma and X17 is your alveolar soft part sarcoma. Okay, so these are the important ones that you have to remember. Now, once we are clear with this, again you have to remember this. Okay, so when I'm talking about this, okay, what are the others, what are the small round cell tumors that you have in your body? Okay, so there are a lot of small round cell tumors. First is this one, Can you see this dark blue nucleus and all these blood vessels also lined by blue color? This effect is called azopardy effect. So whenever they show you azopardy effect, okay, and so blue cells, it has to be small cell carcinoma of lung. Okay. Second is this tumor, which is again a small round cell tumor. If you look at this, what do you see? There is a clear zone. After that, the tumor cells are condensing. Okay, and later there is light, very thinned out cells. So if you look at these cells very carefully, they are like this tennis racket shaped cells. Okay, so this is nothing but embryonal rhabdomyosarcoma. Embryonal rhabdomyosarcoma, remember, it has a cambium layer, that is this layer, which is a clear layer. Okay, which is, they can ask you this, which tumor has a cambium layer? This is very typical of embryonal rhabdomyosarcoma. Again, when we talk about rhabdomyosarcomas, we can have three major types. Okay, remember, I'm talking it here. Okay, so whenever I'm talking about rhabdomyosarcoma, remember PEA. Okay, mutter, PEA. Okay, P is pleomorphic, E is embryonal, and A is alveolar. Okay, A is alveolar rhabdo. Okay, embryonal is very commonly in cavities. Okay, it has a habit of arising in cavities. Okay, very common tumor which arises. I've told you this earlier also story so many times. This was one of the case which I saw when I was in PHC for the first time. It was like grape like mass coming out from a 1-year-old child from the vagina, and I thought like, which tumor is this? And then when I studied about it, I always remember it till now. It is embryonal rhabdomyosarcoma. Same way when I was in my senior residency, I saw the same case coming out from the ear. Okay, and I immediately know this is embryonal rhabdomyosarcoma. Okay, so embryonal rhabdos are small round cell tumor. They have cambium layer. Once you see them, you never forget them. Okay, alveolar rhabdomyosarcomas usually have a very typical translocation, either 213 or 113. Okay, so this is a very common translocation of the PAX gene, which occurs in alveolar rhabdomyosarcoma, which is in the chart above. So go through the chart above. You should be knowing these mutations. Okay, so that's rhabdo. Out of these, which is a small round cell tumor? Embryo. Embryonal is small round cell tumor. Okay, now coming to the third tumor. If you look at this tumor, guys, look at this. So you see here that the cells are arranged in a round pattern like this with the pink color material in the center. So what is this called as? This is called as Homer-Wright rosette, and this is very typical of neuroblastoma. Okay, so neuroblastoma has Homer-Wright rosette. Apart from that, which other tumor can have Homer-Wright rosette? Medulloblastomas can also have Homer-Wright rosettes, which you should remember. Now look at this tumor again. If I'm saying this is a tumor of the skin, and you can see dot-like positivity of CK20. Okay, dot-like positivity of CK20, and in fact I had posted this as a question on my Telegram group yesterday. Okay, giving you a question that which of the following are not CK20 positive tumors. Okay, so this tumor is Merkel cell carcinoma. Remember this always, guys. So Merkel cell carcinoma is a neuroendocrine tumor of the skin, and it is a very highly proliferative tumor, bad prognostic tumor, usually occurs in elderly, and it has dot-like positivity of CK20. So remember, whenever they give you CK20 positive cancers, okay, remember the rule. I've drawn a picture also and given you yesterday on my Telegram group, but just for your purpose, CK20 positive and 7 negative if somebody is giving you. Remember, it has to be either colon or it has to be Merkel cell carcinoma. Okay, and Merkel is dot-like positivity. Okay, but if I'm saying 7 also positive, 20 is also positive, then you think of bladder cancer. Okay, then you think of bladder cancers. Okay, so this is very important point that you have to remember. Okay, now once we have talked about these small round cell tumors, apart from that, lymphoma, especially acute lymphoblastic lymphomas, okay, are also small round cell tumor. That is why you should always look at LCA in the question, and that is why in this question there was a very typical thing written, LCA negative. So which tumors are positive for LCAs? Usually lymphoma, hemat tumors. Okay, so LCA stands for CD45. Okay, so that is why hematological tumors are LCA positive. Remember that. Okay, so if it's LCA positive, you close your eyes and mark lymphoma. You know that it is going to go to lymphoma. Okay, now once we are clear with those small round cell tumor, now let's just some points about small cell carcinoma, because this tumor, if you see, as the party effect, it's small cell carcinoma. Remember, this tumor does not have any pre-invasive phase. Okay, doesn't have pre-invasive. When it occurs, it's very rapid. Okay, it has already metastasized to various places. And the typical thing that you see is, this is one tumor which is very strongly associated with smoking and has maximum paraneoplastic manifestation. Most common paraneoplastic manifestation is syndrome of inappropriate ADH secretion, and the electron microscopy of this tumor is very characteristic because it's a neuroendocrine tumor. So it shows you dense core granules. See, these balls when you're seeing, no, these are nothing but dense core granules. And because it's a neuroendocrine tumor, remember all the neuroendocrine markers are going to come positive. That is NSE, chromogranin, synaptophysin, bombesin, and CD56. Remember, that is also positive. That's a neuroendocrine marker and it's positive in small cell carcinoma. Of course, the mutations are of RBG, P53, and LMIC. Okay, and I hope all of you remember, whenever MIC is mutated, it gives a very high proliferation. Okay, now, right. Till now, any doubts, guys? Let me just see if you have any doubts. Okay, any doubts still here? Yes. So these are dense core granules. So now there is another question for you all. Tell me, which other tumors have dense core granules? Let me see how many of you can answer that. Till the time I'm seeing your YouTube, if you're posting anything. Okay, guys, tell me. So, are there any other tumors which show dense core granules? Okay. So all the neuroendocrine tumor, talk about any neuroendocrine tumor, let it be Merkel cell carcinoma also, any neuroendocrine tumor will show you dense core granule. And one of the biggest category of neuroendocrine tumor is paraganglioma, guys. Okay. So what are paragangliomas? This is another very, very important question that they ask you. Paragangliomas. Okay. So if it is an intraadrenal, okay, intraadrenal, very good, is actually called pheochromocytoma. Extraadrenals can be so many, okay, so many. They can be carotid body tumors, they can be glomus tympanicum, they can be laryngeal paraganglioma, they can be iotopulmonary paraganglioma, and any paraganglioma of that sort will have a very typical pattern called as Zell-Balin. Okay, so they have a pattern called as Zell-Balin. Zell-Balin means that there will be nest of tumor cells and they'll be encircled by specialized cells called as sustentacular cells. These sustentacular cells are S100 positive. And I've told you earlier also, S100 is a marker which is present in many things: melanin, nerves, cartilage, histiocytes, and sustentacular cells. So all of them are S100 positive. Okay, so this is very, very important point. You have to remember, this is the concept of Zell-Balin that everybody should know. And all these neuroendocrine tumors have a very typical chromatin. What is this chromatin called as? Very good. Salt and pepper chromatin. So remember, this chromatin is called as salt and pepper chromatin. In fact, this has been asked as question earlier. Salt and pepper chromatin is very, very typical of which tumors? Okay, so this is neuroendocrine tumors, and this pattern they can give you an exam, guys. You have to remember, this is the nest of tumor cells, and this peripheral layer which is surrounding this is a sustentacular cells. Okay, this pattern is called Zell-Balin pattern. Now here's the question. Let's see how many of you can answer this. Okay, so because many of you are writing, Avantika is already writing a mutation. So, so tell me, Avantika, which of the following is not associated with pheochromocytoma? So this is a very important update. Which mutation is not associated with uh, pheochromocytoma? Salt and pepper means, guys, can you see the chromatin? It's like salt. Some areas are very thinned out, like small dots, and some are coarse, just like your salt and pepper. So if you spill salt and pepper, salt is very thinned out and pepper is coarse. So that is what is called as salt and pepper. Trilok, did you understood? ठीक है, समझ में आ गया? Yes. Okay. So which is not associated with pheochromocytoma, guys? What, Avantika? You're writing NF1, NF2 both. So which is not associated? देखो यार, VHL is definitely associated. Okay, so VHL तो associated है. Okay, NF2 is not associated. Okay. So let us look at that. It is NF1 which is associated with pheochromocytoma. So remember, what are the genes which are associated with pheochromocytoma? One is MEN2. Okay. Then you have to remember here. Okay. So remember, VHL is definitely associated. So VHL associated tumors जब आपसे पूछे जाते हैं, you have to remember what is the most common tumor with VHL. Quickly tell me, what is the most common tumor with VHL? Hemangioblastoma, which is a tumor of cerebellum. Okay, so hemangioblastoma is the most common. Next comes your clear cell renal cell carcinoma. Third is your pheochromocytoma. Okay, so pheochromocytoma. Fourth is your all these hepatic system pancreatic cysts. Then fifth comes these are the common tumors which can occur. Okay, even endolymphatic sac tumors can also occur with VHL mutations. Okay, so remember these are common tumors with VHL mutations. Okay, apart from that, another tumor which you have to remember with VHL, and I'm going to ask you later also, one pancreatic tumor. Serous pancreatic tumors. Okay, so serous pancreatic tumors are also very common with VHL. So remember, hemangioblastoma is very common. Okay, then clear cell renal cell carcinoma. Okay, pheochromocytoma. Okay, then two P's, pancreas and pheochromocytoma. The second P is pancreas, serous pancreatic tumors, and it has a lot of cysts in the liver and pancreas. Apart from that, endolymphatic sac tumors also can occur in this. Okay, so that is VHL mutations which you have to remember. Okay, apart from that, you should remember enzyme mutation is very common in paragangliomas. This is SDH, succinyl dehydrogenase mutation. It can be SDHB, C, D, anything. Okay, apart from that, the new ones which has come is IPAS. Very good, Satvik, I'm so proud of you. So there is a polycythemia which occurs with, this was also a question that I had asked you earlier. Schwarz polycythemia occurs with VHL mutation. So just to explain you a bit, remember, again, I'm just telling, whenever we have a, because if you remember the story, you will be able to understand this better. So whenever we have hypoxia, it produces a molecule called as HIF1 alpha, which will go and stimulate EPO and VEGF. Okay. So this VEGF causes angiogenesis and EPO causes increase in the RBC because body thinks that hypoxia is either due to ischemia or due to anemia. So it will increase RBC, it will increase the blood vessels. Now once your oxygen becomes normal, now this is a very important catch. This will occur when oxygen becomes normal, then your body produces a tumor suppressor gene which is VHL. This VHL will go and break down HIF1 alpha. Okay. So imagine if a person has deletion of VHL, what will happen? So not only angiogenesis will increase, your RBCs will also increase. So this kind of polycythemia is called as Schwarz polycythemia. Okay. So this kind of polycythemia is called as Schwarz polycythemia, which you all have to remember. Apart from that, because angiogenesis is increasing, majority of the tumor with increased angiogenesis is going to occur, and that is why the tumor which is most commonly associated with VHL is a tumor which has lot of vascularity, but it's not a blood vessel tumor. Okay, it's a tumor of the cerebellum. This is called hemangioblastoma. Okay, that's the most common tumor, right? So that is what you have to remember. Okay, so that is why polycythemias are common with VHL mutations. Okay, apart from that, you have to remember there is another gene which has recently come up, which is associated with polycythemia and paraganglioma. This is called EPAS1. Okay, EPAS1. Okay, this is another gene that you have to remember. Is everybody clear with this? Okay, so if you're clear with this, remember these are the mutations which are associated with polycythemias. Okay, with pheochromocytomas. You have to remember, right? Okay. Now, once we have covered the neuroendocrine tumors, guys, this is one another chart that you all have to remember. This is prognosis in neuroblastomas. Please remember, you must have studied in the pediatrics also, so I'll not go in detail, but you have to remember this chart. I'm sure you would have studied it in your pediatrics also. Only one thing I would like to say here, guys, that remember, whenever we have Turkey expression, no, so whenever we are having more Turkey expression, this is favorable. Okay, so favorable is Turkey expression. All the others are mostly unfavorable. Okay, so Turkey is favorable. Apart from that, majority of them are unfavorable. Okay, that's what you have to remember. Okay, please remember that and remember the prognostic factors. Do revise that and go. Okay. Now let's go to this next question, because if we are going to detail of everything, then we're going to get too late. It's already 12. Okay. So this is a 54-year-old male patient who presents with easy fatigability, tiredness, and some abdominal discomfort. And this patient has massive spleen. Laboratory finding shows that he has a WBC of 60,000 with eosinophilia and basophilia. What is the diagnosis? Yes. Okay, so what is the diagnosis? Guys, if you look at this, if you can see all the maturation cells, you can see D-shaped cells, you can see all D-shaped cells, C-shaped cells, neutrophils, eosinophils, basophils. Whenever you see so much shift to the left, okay, so you should remember this is CML. Okay, so yes, very good, Satvik. That's a very good clue. Turk A is acha and Turk B is bura. Okay, so Turk A is acha. It has good prognostic. Very good, right? So this is a garden party appearance which is seen in CML. And what is the diagnosis of choice in this? Diagnosis of choice is fish. But if somebody gives you an exam which is better, fish or PCR, what are you going to mark? Obviously, PCR is better because you can do MRD analysis also. That is why it is more important. Okay, so obviously you can do fish or PCR both. Which is better? PCR is better because you can do MRD, and especially quantitative PCR. That is what you do. And I've talked about all the molecular tests in the last class, so please go through the last class for the molecular tests. Okay, now. Another thing that you have to remember here is another question whenever they are giving you an exam massive splenomegaly. Okay, in hemat, remember at least three possibilities should come into your mind. Remember, it can be CML, it can be hairy cell leukemia, it can be primary myelofibrosis, and of course it can be tropical splenomegaly. Okay, right? So these are the things you should remember. Of course, CML has leukocytosis, okay, and a garden party appearance. Okay, hairy cell leukemia usually has pancytopenia and monocytopenia. That is why atypical mycobacteria infections are very important. Of course, you can see hairy cells in the blood, and the most important thing is bone marrow has dry tap, but the characteristic feature is that 100% of them have BRAF mutations. Okay, 100% has BRAF mutations. If you talk about primary myelofibrosis, because bone marrow is fibrosed, again, you can have leukoerythroblastic blood picture. Leukoerythroblastic blood picture. Again, bone marrow shows fibrosis, and you can see teardrop RBCs. Okay, teardrop RBCs. Right? So that is very characteristic that you have to remember. Primary myelofibrosis also has dry tap. Remember which stain will help you in making a diagnosis. Remember, it is reticulin stain. Okay, so the stain which will help you in making a diagnosis is reticulin. What is the catch point? Okay, if you're getting a fried egg appearance, okay, on reticulin, this is hairy cell leukemia. Whereas diffuse fibrosis, if you're seeing like this, okay, then it is primary myelofibrosis. Okay, so that is what you have to remember. Yes. Okay, very good. Okay, so that's very typical. And of course, if somebody asks you what is a mutation typically associated with primary myelofibrosis, remember, whereas hairy cell leukemia was associated with BRAF mutation, primary myelofibrosis is usually associated with JAK2 V617F, okay, mutation, or it nowadays it can have CALR mutation also. Okay, this is calretinin. Okay, so either we can have calretinin mutation or CMPL mutations. So these are the mutations which are associated with primary myelofibrosis. That are the points that you always have to remember. Very good, Satvik. Good, excellent, Avantika and Satvik. Good. Okay, now let's go to the next question. Again, this is a 13-year-old boy. He presents with easy fatigability for 2 weeks, sudden onset of vertigo. That's a very important clue. Peripheral smell is shown. Okay, so can you see here? So all the cells are these are what are called as hand mirror cells. They don't have any granules, and the cytoplasmic is just protruding like a hand mirror. And vertigo, because it has CNS involvement. CNS involvement with hand mirror cells, you should always think of ALL. Okay, so how do you confirm the diagnosis? Flow cytometry will help you identify which type it is, whether it is B or whether it is whether it's B or it is C. Okay, right. So Avantika, perfect. Calretinin is for mesothelioma. Okay, so that is calretinin. This is CALR gene. Okay, CALR gene is for primary myelofibrosis or essential thrombocytosis. Okay, Right. Let's go to the next question here, guys. 35-year-old male presents with to the casualty with bleeding gums. So let me see how many of you can answer this. So this is not a typical image that has been given to you, but yes, a very important one. You can see a bilobed cells here with lot of granules in the cytoplasm. So these bilobed cells with lot of granules in the cytoplasm, this is very typical of acute promyelocytic leukemia. Okay. So, Satvik, T cell and B cell both can involve CNS. Okay, both can involve CNS. You cannot differentiate them. Only thing is, if it is an adolescent person with a thymic involvement, mediastinal mass, then it points more towards TLL. Okay, whereas B cell usually presents with lymphadenopathy, but flow cytometry is always confirmatory. Okay, both of them can involve CNS. Okay, right. Okay. So if you look at this, this is binucleate cells, guys. These are also called as buttock-shaped cells with lot of cytoplasmic granules. These are very, very typical of acute promyelocytic leukemia. Okay, right. So Avantika and Ramya, why this is not AML-M2? If it is AML-M2, it will show you long and thin or rods. This also can be asked to you as a question. Which blasts have long and thin or rod? So whenever we are talking about long and thin or rods, okay, these are very, very typical of AML-M2, okay, which is also called RUNX1, okay, and RUNX-T1 mutation, right? Right, okay, so that is very, very typical of this. That is what is the mutation. These have long and thin all rods, okay. Whereas if you're talking about buttock-shaped cells with lot of cytoplasmic granule, this is APML, and here the translocation is 1517. Again, if somebody asks you what is the diagnosis of choice here, it has to be FISH or PCR. Again, which you will prefer? PCR, because you can follow up, okay, right. Now, Hodgkin's and just everybody should know, guys. Here the catch. I know all of you are clear with Hodgkin's, you know that. So remember, whenever there's some questions that are asked, I'll just go to the question directly. So EBV negative Hodgkin's lymphoma is lymphocytic predominant Hodgkin, which is also called as nodular lymphocytic predominant Hodgkin lymphoma. Remember, nodular lymphocytic predominant Hodgkin's lymphoma usually are very happy because they have the best prognosis, and so they eat popcorns. So they have popcorn cells, which are also called as LNH cells. So these are happy girls, lady harding girls. So they are happy and they eat popcorns. And they have, because they are girls, no, Hodgkin's lymphoma is a tumor which arises from the germinal center of the lymph node, and it is a B cell lymphoma always. So Lady Harding is a girls' college, so there are only girls there. So one type of people are there, okay. So the background is also made up of B lymphocytes, okay. So it's a B cell lymphoma with background of B lymphocyte. It is going to be LNH cell, okay, LNH cells, okay, right. Yes, JJ, you can do that, okay, right. Naveen, AML M3 has multiple rods which are called as faggot cells. Okay, faggot cells. But you know, in APML there is also there is another variant. Okay, which has buttock shaped cells. So remember, you all remember faggot cells, multiple rods. That is APML. But remember always you should remember, but that they can also have buttock shaped cells. Okay. Now, so remember, lymphocytic predominant is only one type of people. Okay. Remember, LNH, Lady Harding College, it has only girls, so only one type of cells. The background is also made up of B cells. So if somebody asks you which tumor has maximum PAX5 positivity, so PAX5 is a marker of B lymphocytes. So maximum PAX5 positivity is also seen in lymphocytic predominant, and it has the best prognosis, because everybody is happy there, so they're eating popcorns. Now, whereas when we talk about the opposite spectrum, lymphocyte rich, okay, so again lymphocytes are rich here, but 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 okay, this is not Lady Harding, okay, it doesn't have a rich, so it will have the composition of girls and boys, okay. So this is a B cell lymphoma, but the background is made up of T lymphocytes, okay. So the background is made up of T lymphocytes. So remember, lymphocytic rich has a background of T lymphocytes, okay, and they are classical part of classical Hodgkin's lymphoma. They are 1530 positive. So you remember the classical RS cells are seen in mixed cellularity. The background is most important in Hodgkin's. You already know that. Okay. Nodular sclerosis has collagen bands, and because of this collagen band, when you put it in formalin, they retract, and therefore there's a lot of empty space which will be seen, which is called as lacunar cells. So lacunar cells are very, very characteristic of which tumor? Nodular sclerosis. Remember, whenever you do FNAC, so if they ask you which type of Hodgkin cells will not be seen in FNAC, it is lacunar cells, because lacunar cells are a formalin fixation artifact. Okay, that is why they are not seen on FNAC. Okay, Hodgkin cells, or if you cut one eye of the owl, that is mononuclear RS cells, are seen in lymphocytic rich. Okay, so, and lymphocytic depleted has mummified RS cells. Okay, mummified RS cells because they're lymphocyte poor. Lymphocyte poor. That is why lymphocytic depleted, and they have the worst prognosis and maximum EBV positivity. If they ask you which classical Hodgkin's lymphoma can be EBV negative, so remember nodular sclerosis. Nodular sclerosis is one classical Hodgkin's lymphoma which can be EBV negative. Normally EBV negative Hodgkin's is always lymphocytic predominant. But if they ask you classical Hodgkin's which is EBV negative, remember it can be nodular sclerosis, right? So that's an important question that can be asked you from Hodgkin's, and sometimes they ask you what is the gene of Hodgkin's. Who's going to tell me? Let whoever answers get a chocolate. What is the gene of Hodgkin's? Quick, quick, quick. Gene of Hodgkin's. Anybody? Rel gene. Okay, so Rel gene is the gene of Hodgkin's. Apart from that, they express a lot of PD-L1 and PD molecules. So therefore, you give anti-PD-L1 therapies in Hodgkin's. Okay, because so that is what is the genes of Hodgkin's which you have to remember. Now let's come to the another set of questions that they can ask you. This. Let's go to the blood vessel and the heart tumors. Right. Okay, very good, Satwik. You are perfect in saying that. That okay, we'll come to that later, but answer this question. So which tumor is so there's a person, this is a pregnant female, she's having a gum tumor, and people thought that it is just a granulation tissue, and but still they did a biopsy, and biopsy they found this protruded mass with lot of small blood vessels, and this was capillary lobular hemangioma. This is capillary lobular hemangioma. What is this called as? This is called as pyogenic granuloma because people thought that it is some pus material which is there. Later they found out that no, this is a tumor. It's a hemangioma which is called as lobular capillary hemangioma. This is also called as gum tumor. This is pyogenic granuloma. Okay. So remember, this is a pyogenic granuloma, which is a misnomer. It is a lobular capillary hemangioma, which you have to remember. Remember, this tumor always it protrudes like a tree, like a mushroom, with lot of proliferating vessels in it. Okay, so that is your pyogenic granuloma that you have to remember. Okay, okay, so okay, so Naveen, chocolate for you. Perfect. Okay. So can you see these dilated channels which are filled with blood here? So this, if they give you this image, this is an image of cavernous hemangioma. Remember, cavernous hemangioma is one of the most common tumor of liver. Okay, so benign tumor of liver. So most common benign tumor of liver is cavernous hemangioma. Okay, right? So that's cavernous hemangioma, which is the most common tumor of liver. Remember the blood-filled channels with blood. Okay, right. So that is your cavernous hemangioma. Thank you, Satvik, again. Right. Now let's see how many of you answered this question. If you're not seeing this, okay. Okay, so the answer is written. Perfect. So what is this tumor? So it's a tumor which occurs on usually in the nail beds, okay. And when you look at this tumor, they have perfectly round nucleus, and there are some blood vessels in between there, but they are the tumor cells around surround the blood vessels, and they're perfectly rounded nucleus. So which tumor is this? So you see a lot of blue color nuclei all around. Which tumor are we talking about? Which tumor is this? Come on, come on. Glomus tumor. So this is your glomus tumor, guys. Remember the image. Glomus tumor is a tumor which can arise from the nail beds, okay, and they can have lots and lots of, this perfectly rounded nucleus, okay, which we have already talked earlier. That's your glomus tumor, okay. So, Dipesh, this is not chylomicria. For chylomicria, it should be spoon-shaped nucleus. Okay, this is some tumor which is arising just near the nail bed, and it's a very painful tumor. Perfect amanti. Okay. Now, coming to the heart, guys, what all is the important thing that I can ask you? And we have discussed this on my Instagram and my Telegram so many times, which is the stain that we use here to identify myocardial infarction. I'm sure all of you know this now. Okay, so triphenyl tetrazolium chloride. Remember, triphenyl tetrazolium chloride basically stains the LDH, and whenever the membranes are damaged, LDL leaks out, so that area is not stained. Color of TTC can be chocolate, it can be brownish color or red color depending upon the strain that we are using. If you're looking the pale area, that means that's an infected, fresh infarct. If you look at this area, these are glistening white areas, they indicate fibrosis, and that is why they are glistening white. They are old infarcts. Okay, so that's TTC stain which can be given to you in exam, guys. Everybody knows that. Apart from that, you should be, again, you are knowing this. Okay, so a hallmark of rheumatic heart disease are Aschoff bodies, and if you look at them, they contain specialized cells which are called as NHCO cells. Okay, so what is the property of NHCO cells? They have caterpillar-like chromatin, and that is what is NHCO cells called. They are nothing but modified macrophages. Okay. So that is your caterpillar chromatin, and sometimes they can even have, so if you look at them, they are nichco cells, and they can fuse together to form giant cells because they're modified macrophages, and these giant cells are called as Aschoff cells then. So you can have giant cells, you have NHCO cells, you have swollen collagen lymphocyte. So this body together is called as Aschoff body. This is called as Aschoff body. Okay. So that is what is called as Aschoff body, which is a hallmark of rheumatic heart disease. Okay. Is everybody clear for this? Okay. Right. Understood? Right. Perfect. Okay. Once you're clear with this, stage of the MI is another question that they can ask you, and you should be very clear with this chart. So remember, this is the earliest morphological changes, more light microscopic morphological changes. Earliest one is nothing but waviness. Waviness is the earliest light microscopic finding. So this is the chart which I posted for you. Remember this. Till 30 minutes, just a very easy way to remember, till 30 minutes it is reversible. After 30 minutes, it becomes irreversible. And earliest light microscopic finding, which comes after 30 minutes to 4 hours, is waviness, which I've just shown you. Okay. Apart from that, coagulative necrosis starts in 12 hours. Okay. In 24 hours, who's going to come? Neutrophils are going to come. Apart from that, because there is coagulative necrosis, there is hypereosinophilia of the myocytes and even contraction band necrosis. Okay. So in 24 hours, we get neutrophilic infiltration, myocyte hypereosinophilia, and contraction band necrosis. Okay. Once we have got neutrophils in 24 hours, okay, these will be replaced by macrophages on day 3. So neutrophils have come in 24 hours, macrophages will come on third day. So in between that, what will happen? There will be brisk neutrophils. Neutrophils will become very, very brisk in between that 1 to 3 days. Okay. After that, you have to remember, once macrophages come, so in all the other tissues of the body, all the other tissues, the granulation tissue starts forming at day 3. Once the macrophages come, they form the granulation tissue, except in heart. So in heart, the granulation tissue forms on day 7. So that's an exception, and that is why this is one of the favorite question of the examiner. So when is the granulation tissue formed in the heart? Remember, day 7. After that, we have well-formed granulation tissue. Remember, collagen deposition starts on 14th day and it finishes. Okay, so that is 2 weeks. Okay, so it starts in 2 weeks and it completes in 2 months. Okay, that's a simple clue to remember. Collagen deposition starts in 2 weeks and it completes in 2 months. And finally, after 2 months, we get a dense scar. Okay, so once it's scarred, you get a glistening white area on TTC stain, which I've shown you earlier. So that's the changes of myocardial infarction, which is very, very important. Remember, neutrophil 24 hours, macrophage eye third day, for granulation tissue 7th day aayegi. Okay, then collagen will start forming in 2 weeks and it will complete in 2 months. That's the catch point that you have to remember in MI. Okay, now once you're clear, heart is not complete till I show you these cells. These are a very favorite question of examiner. Spider cells. So where do you see spider cells? Spider cells are very classically seen in rhabdomyoma. Okay. So they have a lot of glycogen here. Because of glycogen, this area becomes clear and it just separates from the margin. That is what is called as spider cells, which are seen in rhabdomyoma. Is everybody clear with this? So rhabdomyoma of the heart, okay, very common in children, especially. It's one of the most common cardiac tumor of child, rhabdomyoma, and you see spider cells, right? Perfect, guys. Okay. Okay, now let's come to another set of questions which they ask you. This is again a very common question which is not given in your books. This is FNACs. Okay, so if they're giving you antler horn-like pattern on breast FNAC, this is very characteristic of which. So you know antler horn-like pattern. Whenever they ask you, so this is very common in two conditions. If I'm talking about FNAC, okay, this is nothing but fibroadenoma. Okay, so this is nothing but fibroadenoma, which you should remember, right? But apart from that, on histopathology, there is a tumor called as hemangiopericytoma. Okay, hemangiopericytoma. This also has a stag horn or an antler horn like pattern because it's a tumor which arises from pericytes. Okay, so that is why it also has a stag horn or a antler horn-like pattern. It's a tumor of pericytes, hemangiopericytoma. So if somebody asks you on FNAC you're seeing antler horn-like cells, remember it is fibroadenoma. If you're seeing histopathology, a blood vessel tumor which has antler horn-like pattern or a stag horn pattern, remember it is hemangiopericytoma. So perfect, Satvik. So I've told you rhabdomyomas are a most common tumor in children, usually associated with tuberous sclerosis. So please remember this point also. It's usually associated with tuberous sclerosis. Perfect, guys. Okay. So coming to antler horn, everybody is clear. Remember these 2 points, two differentials in your brain always. On FNAC, it has to be fibroadenoma, whereas in cases of your blood vessel tumor, it has to be hemangiopericytoma. Now, look at this. What happens in FNAC of fibroadenoma? So whenever you're pulling out, the tissue, because it's like a breast mouse, when it comes out, so epithelial cells come out here like this, like a antler horn. Apart from that, there's a lot of myxoid matrix also, and there are a lot of bare nuclei which you can see here, which are called as bipolar nuclei. Okay, they are myoepithelial cells. So in breast, myoepithelial cells are very, very important. If the myoepithelial cells are there, that means if the lesion is benign. So if you're looking at the epithelial clusters, stromal fragments, okay, stromal fragments and benign fragments and benign bipolar nuclei. Benign bipolar nuclei is nothing but myoepithelial cells. So if you see these three things, epithelial cells, stromal fragments, and benign bipolar nuclei, this is very typical of fibroadenoma. This was also a question which I have, you must have seen so many times. So if there is an absence of benign bipolar nuclei, that means the lesion is not benign. Okay. So if I talk about the origin of the breast tumors, this is one of the very favorite question of the examiner. You should remember fibroadenoma basically arises from lobular stroma. It's a tumor from the lobular stroma. That's the site from where the fibroadenoma and Phyllodes tumor arise. It arises from the stroma. Okay. Whereas when I talk about TDLU, okay, terminal ductal lobular unit, this is the area from which your cancer, carcinoma, hyperplasia, and everything arises. Okay. Whereas when I'm talking about, large ducts, okay, this is the area where Paget's disease and ductal ectasia occurs. So Paget's disease and ductal ectasia occurs in the large ducts. Now, if I'm talking about this stroma, interlobular stroma, this is the area from where you get sarcomas, fat necrosis. This occurs in the interlobular stroma. So what is the site of region of, somebody asked you, what is the site of region for fibroadenoma or Phyllodes tumor? It is intralobular stroma. It is intralobular stroma. This is the stroma from which this arises, this green one. Okay, intralobular stroma. So remember, fibroadenoma and Phyllodes arises from intralobular stroma. That's the catch point that everybody has to remember. Interlobular stroma give rise to fat necrosis, TDLU, which gives to hyperplasia, carcinomas, and large ductal ectasias and Paget's. Perfect. So that is very, very classical that everybody has to remember. So if you're clear, let's come to this question. Let's see how many of you have understood the question. Okay. So this is a 20-year-old female. She presents with 1 centimeter breast mass. A diagnosis of a fibroepithelial lesion is made. What is a fibroepithelial lesion? A tumor which has both fibro component and epithelial component. That is a biphasic tumor. So fibroadenoma is a biphasic tumor. Okay. Or if you look at this, phyllodes is a biphasic tumor. So phyllodes and fibroadenomas are considered as fibroepithelial lesion. So which histopathological feature is consistent with the diagnosis of fibroadenoma? So they are asking which of these are consistent with fibroadenoma. So circumscribed borders are classical features. Breast mouse is fibroadenoma. Stromal atypia, stromal condensation around the gland, stromal overgrowth. These all are features of phyllodes. Okay, so that is what you have to remember. Okay, so that is what you have to remember. Okay, so of course, if you can see here, there's a lot of stroma which is growing, and that is why the ducts have been compressed. Okay, so you can see a lot of compressed ducts here. That's a very classical feature of fibroadenoma. But if there is lot of growth, stromal overgrowth, even stroma becomes atypia, and it condenses around the epithelial cells, then you should start thinking of phyllodes. So if somebody asks you, out of these three, which is the most classical feature of phyllodes? So this stromal condensation of around the glandular structure is the most characteristic feature of phyllodes tumor. Okay, so stromal condensation around the glandular structures is the one which gives it typical appearance. That's a phyllodes tumor. That's the earliest thing that occurs. And then we have phyllodes tumor. It also has a leaf-like pattern of growth, which you all have to remember. Now, again, another question that they ask you in breast cancer, because breast cancer, one thing which you study in surgery also so much. So I'm just concentrating on pathological features. So genes of the breast cancer are very, very important, and they ask you so many times. You remember 60% of the breast cancers are sporadic and therefore associated with P53 mutation. But in familial breast cancers, now they have divided into high penetrant genes and moderate penetrant genes, which you have to remember. Remember the moderate ones, others are all high penetrant. Okay, check 2, which is basically responsible for radiation induced breast cancer, is moderate penetrance, and ATM is moderate penetrance gene. Okay, right. So that is your moderate penetrance. Okay, so oh my God, Sumit is saying he's feeling sleepy. Maybe I'm making you sleep, guys. Whenever you are tired, you tell me, and we'll just close the sessions. We can have the session some other day also. It's okay. I know today must be the big day for you because your admit cards have come. Yes, so that is why you must be feeling that you're close to exam. Okay, and so if you feel sleepy, if you feel that okay ma'am बहुत थक गए अब सोना है, so do let me know. We can close the session definitely, and we can have the session maybe tomorrow or whenever you say. Okay, right? So do let me know, guys. Okay, and don't sleep. Okay, right? So these are the genes causing breast cancer. And remember, the moderate penetrant ones are ATM and check 2. Okay, right? Okay. So once you clear with this, who can identify this? Okay, who can identify this? So these are the epithelial cells with these nuclei which are here. These are big cells with clear cytoplasm. What are they? They are Paget cells. Okay, so these are Paget cells. Remember, Paget cells are very typically seen in two important organs of the body. They are breast and vulva. Okay, breast and vulva. So what is the unique point of each of them? So breast phages is always associated with underlying malignancy. Okay. So breast, okay, uh, is basically associated with underlying malignancy. 100% of them have underlying malignancy. In vulva, only underlying malignancy is seen in 12% of the cases. Okay, so in vulva, the underlying malignancy is seen only in 12%. Okay, so that is what you have to remember. So underlying malignancy is always present in breast. Okay, that is one thing. Apart from that, you remember these Paget cells are usually positive for HER2/neu. They will be PAS positive. They will be mucicarmin positive. Okay, okay, and there will be CK7 positive also. Okay, so these are Paget cells. So they are HER2/neu positive, they are PAS positive, they are mucicarmin positive, and they're CK7 positive also. And remember, the difference lies in the underlying malignancy. Breast, 100% of the underlying malignancy is there. Okay, now once you clear with the breast, let's go to the another question that they ask you. Okay, So let's go to this question, guys. So this is a 40-year-old female with fever and epigastric pain, and her hematocrit is 24%, and the platelet count is low. LDH is high. Okay, so that means there is hemolysis occurring with thrombocytopenia, and peripheral smear shows you these cells. What are these? Schistocytes. Now, you always, when you see schistocytes, you have to see for PT and APTT. If your PT and APTT is coming normal along with these cells, that means this is a thrombotic microangiopathy, which is not DIC. If your PT and APTT are prolonged along with this is DIC. But if your PT and APTT is normal, then you should think of thrombotic microangiopathy, which majority of the time basically can either be, you can classify like this. Okay, so whenever I'm saying thrombotic microangiopathy, please remember like this: PT, APTT, normal, abnormal. If it is abnormal, then it is DIC. If it is normal, we have two differential, TTP and HUS. Okay. Now, how do you differentiate? TTP is due to deficiency of ADAMTS. Okay. HUS is two types. Okay. Typical and atypical HUS. Okay. Atypical HUS is complement mediated. Basically, it is complement mediated. So, due to deficiency of complement regulatory proteins like factor H and factor S. Okay, whereas typical ones are due to your E. coli, or it can be due to Shigella. Okay, so these are all Shiga toxin producing organisms. So all these basically cause endothelial deficiency. Very good. So Upshaw-Schulman syndrome is a congenital TTP. Okay, Upshaw-Schulman syndrome is congenital TTP. Now, out of these, now let's come to which is the option given here. So this patient is showing you your thrombocytopenia with schistocytes. That means there is definitely thrombotic microangiopathy going on. So, you know, in thrombotic microangiopathy, what happens is because of all these causes, thrombus is formed. So, when the RBCs are passing through the thrombus, they undergo lysis. So, there's thrombocytopenia. Why there's thrombocytopenia? Because platelets are consumed in forming thrombus. So, there's thrombocytopenia. And because RBCs have to pass through this thrombus, they undergo fragmentation and they become helmet cells, which are also called as schistocytes. Okay, so whenever you see schistocytes and thrombocytopenia, if it is due to TTP, you have deficiency of ADAMTS. That is what you have to remember. Okay, if they give you diarrhea, child, then it is typical HUS. Okay, pregnancy with normal APTT, PT, with cysto, thrombocytopenia, think of atypical HUS. Okay, right. Perfect, guys. That is what you have to remember in these thrombotic microangiopathies. Okay. Now, let's come to the lung. In lung, which question they usually ask you is the pneumoconiosis. Here I've given you one chart basically to compare all of them. So, just to tell you, whenever we have coal workers disease, usually it produces centriacinar emphysema. So, if they're giving you centriacinar emphysema along with, black pigment in the lung or dust cells, this is your coal worker disease. If they're giving you silicosis, guys, you should remember silicosis starts with S. S basically usually involves upper part. Okay, so silicosis usually involves upper part, whereas asbestosis always arise A. What comes after A? B. So A occurs in the basis down. Okay, S usually goes up. Okay, sun is up. Okay, so silicosis is always up because it's like a sun. Okay, so it's occurring in the upper part of the lung. That's number one. Number two, it causes extensive fibrosis and it can cause eggshell calcification. Okay, and on the CT lung, it can cause crazy pavement pattern like COVID. Okay, crazy pavement pattern like COVID. Okay. Apart from that, asbestos bodies also causes fibrosis. This is interstitial fibrosis. Apart from that, it will have typical bodies, which can be a spot image that can be given. So these usually when they are dumbbell shaped bodies with a clear core like this, these are called asbestos bodies. Okay. Now, if suppose they develop iron, so normally macrophages will eat them and they will deposit iron on them. If they deposit iron on them, they are called as ferruginous bodies, which will appear like this, and they will be positive for Pearl's Prussian blue. If somebody asks you which is the most common cancer which occurs here, so you remember asbestosis usually give rise to mesothelioma, but mesothelioma occurs after a long latent period, okay, after 25 to 40 years, okay, that is what occurs in asbestosis, okay, long latent period. So you have to understand the difference between asbestos bodies and ferruginous bodies, and they can be asked as a question. Till the time the core is transparent and clear, they are asbestos bodies. If they become golden brownish, they are basically ferruginous bodies, right? Okay. So once you're clear with this, before just one question. So who will tell me what is the gene which is involved in mesothelioma? If a person is developing mesothelioma, which gene will be involved here? It is usually BAP1. Okay, so the gene which is involved here is usually BAP1. Okay, and mesothelioma occurs in the peripheral part of the lung. So usually it is confused with adenocarcinomas of the lung. So how do you differentiate mesothelioma from adenocarcinoma? Mesotheliomas will usually have long and thin microvilli. Okay, so long and thin microvilli. And if you do IHC, they will be positive for CK56, okay, and they will be positive for calretinine, okay. So calretinine and CK56 are markers for mesothelioma. And on electron microscopy, they will show you long and thin microvilli, okay. So that is very characteristic of mesotheliomas. Mesotheliomas are confused with adenocarcinoma of lung because both of them are peripheral, okay. So in alpha 1 antitrypsin pan is in RM5 is seen, okay. Now once you're clear with this, let's look at one image, guys, before we go to anything further. Okay, so I thought I'd kept an electron microscopy for you. Basically mesothelioma electron microscopy is a spot image, guys, so please remember that, okay. Right, okay, so that is your mesothelioma which you all have to remember. Perfect, guys. Okay, so that is your mesothelioma, which everybody has to remember. So I hope you're not afraid, seeing that I have kept a lot of session for you. Okay, we'll finish quickly, and we can have another session afterwards also. So answer this question: which of the following condition bone marrow biopsy is preferred over bone marrow aspirate? Let me see how many of you are awake. Okay, so let me see how many of you are awake quickly. So, in which of the following bone marrow biopsy is preferred over bone marrow aspirate? TB, megaloblastic leukemia, or Kala, sir? So guys, BRAF1, BRAF2, it is basically BRAF B600, V600E basically, and there is another BRAF mutation which usually occurs in pilocytic astrocytoma. All majority of the cancers like LCH, papillary carcinoma of thyroid, or this hairy cell leukemias, okay, and colon cancers, they usually occurs because of BRAF60E, right? Okay. So the answer to this question is, guys, tuberculosis. Okay, why? Because tuberculosis usually has granulomas, which is associated with fibrosis. Therefore, they don't come on aspirates, and you miss the lesion. So remember, in all the other conditions, diagnosis can be made on bone marrow aspirate, except okay, uh, except uh, except you should remember TB. Okay. Thank you, Rebhav. Okay. So that's that's just jinx. Okay, I will say that. So in TB, basically bone marrow biopsy you have to do because granulomas usually come from biopsies, not on aspirates. Okay, so remember that question. That's a very important question and can be asked you. Okay, so I hope everybody knows this is the bone marrow aspirate needle. This is having a screw, so this is Sali needle, no screw, Klima needle. But look at this lesion. I hope you know this is the pink material is caseous necrosis with Langerhans giant cells. So this usually will not come in bone marrow aspirate. That is why you have to do bone marrow biopsy. Whereas you look at these These are nothing but, safety pin like structures, T-shaped structures. Okay, so you can highlight this and see. Okay, so they have one big nucleus and then one small dot after that. These are nothing but LD bodies. Okay, so they are nothing but LD bodies. So whenever we're talking about LD bodies, they can be seen on a bone marrow aspirate as well as bone marrow biopsy. So you don't need to do biopsy. Okay, that is why it is very, very important. And apart from this, you have to remember whenever I'm talking about organisms, okay, we have talked about TB where you have to do biopsy, we have talked about LD bodies which can be seen on aspirate. You know these bodies, these with Maltese cross, okay, which appears like, multiple dots, but they are usually like Maltese crosses. So they are very, very typical. Remember, Maltese cross appearance is basically seen in Babesia. Don't forget, this is a very important question that can be asked you in your exam. This is Babesia, guys, okay? And Babesia is usually a tick-borne disease. It is caused by a tick, okay? That is why you have to remember this is Babesia. It has a Maltese cross, okay? Very important image-based question can come in exam. You should remember that, okay? Right. Okay, this is seen in peripheral blood. And of course, all of you know these banana-shaped gametocyte with multiple ring in the RBCs. It is falciparum. Guys, I've discussed this more on the yesterday's section also, yesterday's class also. So please see that also. Okay, so these were the parasites which all of you should be knowing in hematology, and they can be asked you in question. Next important question that they can ask you is from the salivary gland. Okay, so which is not a malignant salivary gland tumor. So I have taken a video, complete video on salivary gland tumors in the YouTube, which you can see. But which of the following is not a malignant salivary gland tumor? Remember, Warthin is a benign tumor. So if you look at the classification of the salivary gland tumor, when we talk about the benign tumors, we have pleomorphic adenoma, we have Warthin, oncocytomas. Okay, so pleomorphic adenoma and Warthins are typical benign tumors, whereas mucoepidermoid is the most common malignant tumor. Okay, acidic cell, adenoid, cystic, they are typical malignant tumors that you have to remember. Okay, now, so if I'm talking about most common malignant minor salivary gland tumor, so minor salivary gland adenoid cystic tumor is very common, especially in the larynx. Okay, so minor salivary gland tumor of the larynx, malignant tumor is adenoid cystic usually. Okay, so if I'm talking about the salivary gland tumor, this is the gist image that I've drawn. Okay, so remember, which is the most common benign tumor of the salivary gland? It's pleomorphic adenoma. Most common malignant, mucoepidermoid. Okay. So if they give you a lot of, these chondromyxoid matrix, that pink color chondromyxoid matrix with myoepithelial cells and some, glandular component, this is pleomorphic adenoma. And remember the mutation here is PLAG1. Okay. That's the mutation, which is a growth factor receptor family molecule, PLAG1. So PLAG1 mutation is seen in pleomorphic adenoma, right? Now, if I'm talking about Warthin tumor, again, it's a benign tumor. It is also called as papillary cystadenoma lymphematosum. And this usually occurs only in parotids. This was another question that was asked to you in exam, which is the one tumor which occurs only in parotids. So this is Warthins, usually occur only in parotid and especially in smokers. Very good, the Satvik, you told correctly. So usually in males and smokers it occurs, okay. And if you look at this, they have a lot of lymphoid follicles. So there are very few tumors which have lymphoid follicles in them. In thyroid, remember Hashimoto. In salivary gland, remember Warthin tumor, okay. So there are a lot of lymphoid follicles which are lined by epithelial cells which are double layered. Okay. So you see the epithelium is very, very pink. Okay. So the epithelium is very, very pink because it is made up of oncocytic cells. So what are oncocytic cells? Cells which have a lot of mitochondria, and that is why they stain very, very pink. And because they have a lot of mitochondria and lymphoid follicle which pushes the epithelium, therefore they're usually thrown into papillary projections. So if you look at this tumor, it has papillae. Okay, it has papillary projection. That is why this tumor is called papillary, because it's papillary. Okay, and it has usually cyst, which has very murky fluid in it. Okay, so it's usually a cyst. So that is why cystadenoma, papillary cystadenoma, and because it has lymphoid follicles, lymphomatosum. So papillary cystadenoma lymphomatosum. is the other name of Warthin tumor, which you all have to remember. Okay. Now, coming to the malignant salivary gland tumor, most common is your mucoepidermoid. Name itself says muco and epidermoid. So it has mucin-filled cyst and it has squamous epithelial cells. Okay. So because it has a mucin-filled cyst, this mucin are positive for mucicarmine. Okay, so this mucin stains are positive for mucicarmine. And if you put staining, this will be positive for 1119 translocation, which is nothing but MECT. So mucoepidermoid has everything from M. So MECT, MAM, L2. That's the translocation which is seen in mucoepidermoid. So everything for M is your mucoepidermoid tumor. Now coming to your adenoid cystic cancer, remember adenoid cystic cancer is very, very typical. It is called cookie cutter appearance. Okay. So what is it called as? Cookie cutter appearance. So whenever I'm talking about cookie cutter, so it's perfect rounded nests which are there, surrounded by epithelial cells, and they also show you perineural invasion. Okay, so it invades the nerves, and this cookie cutter pattern is also called as cribriform pattern. Okay, so cribriform pattern. Okay, so cribriform pattern is a pattern in adenoid cystic tumor. Remember cribriform. Okay, so yes. So remember, if somebody asks you that out of these which are benign, pleomorphic adenoma and Warthin are benign, which are malignant, they are mucoepidermoid and adenoid cystic. So adenoid cystic invades the nerves, so it can be painful tumor. In mucoepidermoid, more the squamous cells, higher the grade. Okay, so somebody asks you which is the higher grade, more the squamous cells, higher the grade. Okay, so that's very, very typical of this tumor, right? So this is what salivary gland tumor, but it doesn't end until unless you know the classifications which can be given to you in exam. So for all the salivary gland tumors, we follow one classification system on FNAC. This is called Milan system. So if somebody asks you Milan system is used for which group of cancers, it's salivary gland cancers. Okay, so Milan tumors. So Milan classification is for your salivary gland tumors. And we have just studied glomus tumor. So what is the classification for glomus tumor? It is fish classification that you have to remember. Fish is your glomus tumor. Okay. Apart from that, breast is Mr. Robinson. Okay. So breast classification is Mr. Robinson. Okay. Paris is your bladder. Paris is your bladder. Marsh is your celiac disease. And Bethesda is your thyroid and cervix. Okay. Thyroid and cervix. Okay. So these are the classifications which you should remember. Remember, Bethesda is very simple. Cervix and thyroid. Marsh is basically marshy celiac. Okay. Paris. Okay. So Paris is bladder. Okay. So PB stands for Punjab. Okay. So Paris is for bladder. Fish is glomer. What comes in alphabetically close to F? It is glomus. That is good. And everybody wants to do MS. Okay. So that is why Milan is salivary gland. Okay. So Milan is salivary gland that you have to remember. That's our classifications which everybody should know. And this was also a question that was asked earlier. So you should know what is the criteria for adequacy in thyroid first. So if you're doing a thyroid FNAC, what is the criteria for adequacy? You should have at least 6 groups of follicle cells. Okay, right? And each group should have at least 10 cells. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Like this, you should have, okay, you should have at least 6 groups. Okay, 1, 2, so I'm just drawing it like this. Okay, so like this you should have 6 groups. Okay, like this you should have 6 groups. Okay, like that you should have 6 groups. Then it is considered as adequate FNAC. And what is the exception to the rule? What is the exceptions to the rule? So exceptions are three. Okay, what are three? One, if you have thyroiditis. So if you have thyroiditis, then there are a lot of inflammatory cells. You cannot, you can, even if there are less epithelial cells, you can leave it out. Second, benign colloid nodule, which is lot and lot of colloid. So if only colloid and foamy macrophages come, that is also considered adequate. Okay. And apart from that, if you get any malignancy, then of course you don't wait for adequacy. You would immediately report it as malignancy. So remember the rule is 6 clusters of 10 cells. Okay. So that is why I've drawn the diagram so that it remains in your brain. Okay. We should have 6 clusters of 10 cells. Okay. That's the criteria for thyroid epinacy. And what are the 3 exceptions? Remember. Okay. So if you have the inflammation, if you have malignancy, if you have a lot of colloid, benign colloid nodules, then you can meet the adequacy. Okay, remember that always. Okay, so Satvik, very good. Gleason scoring is used for prostate. Everybody knows that. Okay, right. Now, if you're talking about Bethesda of the cervix, that is pap smear, again, the adequacy criteria is a question that can be asked. So, how many cells, how many squamous cells do you need? So, approximately 8,000 to 12,000 squamous cells in 10 high power field you need, okay? But if you're doing liquid based cytology, which I've discussed in the last class yesterday, please go through that. Then you just need 5,000 cells, they're enough. Also, you should remember at least 10 endocervical cells should also be there, okay? At least 10 endocervical cells should also be there. Even if the female is less than 40, you don't need that, but otherwise it should be there. So you should have it. Pap smear should always be taken from squamo-columnar junction. So you should have squamous cells and columnar cells for adequacy. So how many squamous cells? 8,000 to 12,000 squamous cells plus endocervical cells, at least 10 should be there. And for liquid based cytology, you should have 5,000 cells. Okay, that is very, very, very important that you have to remember. Now look at this image. So if I'm telling you, is this adequate or not, you have to tell me. So first image, do you think this is adequate? It shows you lot of colloid with some foamy macrophages. So yes, it is adequate. Can you see lot of inflammatory cells with some cells with pink cytoplasm? So a lot of inflammation. Okay, so you don't get clusters of epithelial cells here, follicular epithelial cells, but a lot of inflammatory blue color cells here. So yes, this is also adequate. So when you do the biopsy, here you found that there were a lot of colloid. This was a solitary colloid nodule. And in this biopsy, you saw this follicles along with the Hurthel cells. So this was Hashimoto thyroiditis. So yes, it is adequate even without seeing 6 clusters of follicular epithelial cells. Okay. Now that was about your FNAC questions that can be asked to you. Now let's come to another set of questions, that is pancreas. Okay. So look at this question, guys. This is a 70-year-old female with a mass in the tail of the pancreas and it has VHL mutation. Do you remember which pancreatic tumor has VHL mutations? We had discussed it. So yes, it is a serous cystic neoplasm, which we have already discussed. But the catch point here that you should remember is central scar. So there are very few tumors with a central scar. So it's a cystic tumor which has small cysts, has microcysts with a central scar. This is very typical tumor of pancreas. This is serous pancreatic tumor, okay, which all of you should remember. Now, look at this question again. Let me see how many of you know this question. So, which tumor is called as Hamaudi tumor or France tumor? Anybody who can answer this? Which tumor is called Hamaudi tumor or France tumor? So, which tumor? SPEN. Okay, so pancreatic pseudopapillary neoplasm is called as Hamaudi tumor or France tumor, and they typically have mutation of beta catenin. Okay, beta catenin is also called as CTNB1. Okay, that is this. Okay, so that's a very typical mutation which is seen in SPEN. So you should always remember this. Okay, so that's your SPEN that you always have to remember, and this usually occurs in young females, which you already know. Okay, right. Okay, where do you see GNAS mutation? So GNAS mutation, I have already given you a question. Okay, it is seen in pituitary adenoma. So GNAS mutations are very common mutation of pituitary adenoma. And if somebody asks you any pancreatic tumor shows you GNAS mutation, yes. So this is intraductal papillary mucinous neoplasm, IPMN, shows you GNAS mutation. Whereas KRAS mutations are very common in mucinous tumors. Okay, so that is the tumors. Okay, so we have seen just now VHL is seen in serous. Okay, VHL is seen in serous. Okay, IPMN shows you GNAS, mucinous usually shows you KRAS, and SPEN shows you beta catenin mutation. So that's all about cystic pancreatic neoplasms. That's all about mucinous neoplasms with the pancreas, which you should remember. Remember, Hamaudi tumor is the other name for SPEN. Never forget that. Okay. Apart from that, you remember that there are some genes which predispose to pancreatic tumors. It can be BRCA2, which can predispose, or it can be P16, which is familial atypical multiple mole melanoma syndrome, or it can be hereditary pancreatitis due to PRSS1 or SWINK1, or it can be Peutz-Jeghers, which has the maximum risk of pancreatic cancer, which is due to STK11, okay, which is due to STK11 or LKB1, and of course HNPCCs. So these are the tumors which typically have higher risk of pancreatic cancer. I hope you remember BRCA also has a very high risk of breast cancers, breast and ovarian cancers. Okay, right. Yes, perfect, Satvik. So KRAS mutation is a very common mutation in pancreaticobiliary area. So KRAS mutation is one of the most common mutation in the pancreaticobiliary area. Somebody asks you which pancreatic tumor? Mucinous pancreatic tumor. Cholangiocarcinomas. Okay, in lung also it occurs in adenocarcinomas. Okay, apart from that, colon cancers also have KRAS mutations. Okay, so then these are about KRAS mutations which you should all know. So if I'm talking about central scars, guys, apart from the serous tumors, you should remember oncocytoma also has a central scar. Okay, so oncocytoma, especially of kidney, has a central scar. Sometimes chromophobe RCCs can also have a central scar. But if you're getting this mahogany brown color, so this mahogany brown color just indicates a lot of mitochondria as well. That is why you're getting this color. So that is typical for oncocytoma kidney. Apart from that, FNH. Okay, so focal nodular hyperplasia of the liver also shows you central scar. So these are some conditions with central scar which you should remember: FNH, oncocytoma of kidney, and serous tumor of pancreas. Right? Perfect, guys. You should know this. Now, these are two important spotters that they can ask you. Remember, whenever the hepatocytes become homogeneously pink and abundant pink in color, this is very typically called as ground glass hepatocytes. And usually, this is because of HBS antigen, and it is seen in chronic hepatitis. Okay, it is seen in chronic hepatitis. This change is not seen in acute hepatitis. Okay. Apart from that, also remember lymphoid aggregates. Okay, lymphoid aggregates in the portal tracts like this. Okay, lymphoid aggregates in the portal tract whenever you are seeing here. Okay, this also this can be seen as hepatitis C virus. So lymphoid follicles basically are seen in hepatitis C virus, and remember they occur because of first there is bile duct injury. First there is bile duct injury, and then there is bile duct proliferation, and that is why it shows you this. Okay, so bile duct injury and bile duct proliferation basically causes you this. Okay, so that is hepatitis C virus. Okay, right. So somebody said about fibrolamellar carcinoma. So guys, fibrolamellar carcinoma, it has a very typical finding, that is it has lamella of tumor cells, and all these tumor cells have a very pink cytoplasm. Okay, along with lot of fibrosis going on. There's a lot of desmoplasia going on. So fibrolamellar carcinoma of liver is very unique because it occurs in females equally as males. And remember, the all the predisposing conditions of hepatocellular cancer does not occur in fibrolamellar cancers. Okay, so that is very very typical. So these are the two you should remember: hepatitis C and hepatitis B, which you should remember. Apart from that, look at these. So if you look at this, this is a very pink color bodies which are seen as hepatocytes. So if you look at these pink color bodies in the hepatocytes here, these are called as Mallory-Denk bodies. These Mallory-Denk bodies are nothing but they are made up of cytokeratin 8 and 18 along with the ubiquitin. Okay. So this is called as Mallory-Denk bodies, and all of you should remember Mallory-Denk bodies are seen as it can be seen in any condition of liver, okay, except secondary biliary cirrhosis. So you should remember where they are not seen. They are not seen in secondary biliary cirrhosis. Okay, that is the point that you always have to remember. So primary biliary cirrhosis has already bodies, but they're not seen in secondary biliary cirrhosis. That's a question that they ask you, right? Okay. Now let's come to the GIT. Or guys, I think it's too late. We should stop here and we can have the session tomorrow. Is it okay? Because it's already 1:15, so it's quite late. I think you should sleep now, otherwise you'll not be able to study. So we can have a session tomorrow if you like. We can continue tomorrow. So shall we stop here at the liver, and then from GIT we can start tomorrow? Yes. Okay, guys. Okay. Okay. Right, guys. So we can stop the session here, and tomorrow we can have a session again. Okay. Tomorrow we'll meet again and quickly we'll have some, important tentative questions. Tomorrow we can discuss for 1 hour. Okay. So which time is convenient for you? Tell me the time so that we can have at that time only. Is it okay if we do it at 7 p.m.? Is it okay? So 7 p.m. is not a jinx time for me. So it might. So what time do you think we should have it? 7 p.m. Is it okay, guys? Quickly, come on, vote yourself. Come on, guys. Tell me. What time? 7 p.m.? Yes or no? Nobody's writing time at all. Nobody's writing. Come on, guys. Tell me what time. Mithun is saying 11. 11? 7. Okay, 7. So majority of you. Okay. Satvik is 7. Kshitij is 7. Okay. Okay. Avantika is 11. My God. So let's have it at 7 so that if there are important questions, we can quickly discuss them. Or Mithun is again saying 11. Satvik is saying try at 7. It doesn't then go in at 11. So Avantika is writing again and again. 11, 11, 11, 11, 11. Okay, we'll try at 7. Okay, otherwise we'll go at 11. Right? 7 is not a jinx time for me. It usually stuck at 7. Okay, Avantika, third time you're writing. Gaurav, you're also writing third time. Fourth time. 11, 11. My goodness. Let's try at 7 and then we can go at 11 if it doesn't work. Gaurav, 10th time you're writing. Okay, guys, bye bye. Good night. We'll try at 7 and then we'll try at 7. Okay, so that we can quickly finish up. Otherwise, you'll tell me, ma'am, you didn't told me jinx question of pathology. I'll tell you the jinx question and I'll keep posting every day also. Maybe some questions on quizzes also. And please keep updated on my Instagram, which is Dr. Vandana Pathology, or on my Telegram, which is also Dr. Vandana Pathology, or on my Facebook group, which you all know, Dr. Vandana Pathology Study Circle, or on the YouTube, which you know, Dr. Vandana Puri. With that, signing off, guys. We'll meet you tomorrow at 7 p.m. Bye bye. Good night.